All right. Good morning, Dr. Herre. Thank you so much for coming on to chat with us. I'm super excited to have you on here, not only to hear about you and your practice that you've built, but we also just recently collaborated on a patient together recently. So I'm really excited to have you on here.
Yeah, good morning. Thanks for having me. Yeah, that was a lot of fun doing all that.
Oh, yeah, it was great.
Yeah,
I'm always super excited to meet other professionals out there that have gotten it for years and are getting it and spreading the word and sharing all the good stuff. So the amount of lives that you're touching is just
yeah.
phenomenal. So
Well,
I
I know
thank you for that.
sometimes doing seems like virtual or online, Myo can be a challenge. But I think this last year and a half, everybody's become such a pro at it. That case that we collaborated on, she had amazing results. I mean, she did so good with all her therapy and um, those ones where they notice a difference like right away are
Yes.
always the most fun when they kind of you can feel something. So
Oh my
that
God,
that that,
yes.
that was
And
a good
she
case.
she did. I mean, she
Yeah,
emailed us right away. She was so excited. And we're going to talk about it a little bit today, a little bit later on. But one of the things that I loved working with you is the report that you sent us after. It was so great. Sometimes I think some providers forget about the myofunctional therapists, and don't really always send us the reports. Sometimes I feel like I'm hunting people down for their reports after seeing patients. So we totally appreciate, you sending that over to us. It was just amazing.
well, that's been one of the game changers for me is having that like templated report that my team uses for any like a consult or especially like post-op and stuff, because I feel like one of the things that's always missing, and it's not just with a myofunctional therapist but with any provider,
Mhm.
that no one really chats.
Yes.
And especially I know that's seems to be the medical model, but especially dental as well, where a lot of these cases that we're working on, you may have the myofunctional therapist or a chiropractor or there could be a lot of people involved,
Mhm.
but if no one really knows what's going on with the other or what they're doing and stuff, I always think it's a challenge. So
Oh, yeah.
I think it's good to try to keep people up to date, but then
Mhm.
and these people, patients or parents come in and they get so overwhelmed at times, like, oh my gosh, this is so much information, right?
Yes.
And it's like, oh, it's okay. You don't have to memorize it all. Like, we've
Mhm.
got it, we've got the info compiled. We'll send it to your
Yep.
care team and they'll have you handle it and
Yeah,
all that.
it's
So
so
it's,
it's
it's been
just
really
so
good for me to streamline that within my community of with the providers that I work with.
yeah, it's so important. My colleague and I were just recording lectures for this like mini course that we're coming out with
Yeah.
about like integration of Myo into the office. And one of the parts is just the importance of messaging, the
Yeah.
messaging between yourself and the patient, between you and the other providers. So that way, when the patient goes, the patient is willing to go see whatever providers they have to. We need to make sure that they're getting the same message everywhere they
Yeah.
go, that we're all, oh, that's awesome. You went in for an adjustment with, the chiropractor, or awesome, you're in this appliance now. And
Yeah.
it's just so important that we can provide that
Yeah.
collaborative care and that whole health to our patients.
Well,
So
I think it's good because, especially if we're just talking there, people get so confused with it, not only patients, but I think between providers, because there's so many different ways to diagnose and to
yeah.
classify and to look at it. And, there's never really been a consensus on it.
Mhm.
So, a lot of your previous guests, I know there are some people, in the country with like Breathe Institute or Dr. Baxter, some people that are working on, trying to streamline that and make it to where there is a, hey, like this is research validated, let's diagnose this way, and try to get all the providers on the same
Mhm.
page. So I think even just talking, okay, well, you see it this way, I see it this way, but it's really the same thing, it's just a
Right.
different classification, right? And so
Right.
I think that really helps with the communication between providers, but with your patient as well.
1,000%. And
Yeah.
this is funny. This is actually the first episode that I have that we hadn't, the first question that we got into wasn't like you sharing your story. Like we totally just started chatting, which I think is really,
Yeah.
really cool. But I do want everybody, to hear your story, your journey into Airway, what got you here. I know you have in your bio when I recorded last night, your own experiences that got you into Airway. I know you're associated with the Breathe Institute, you're an affiliate there. So tell us a little bit about your story and when you had like that aha moment.
um I was lucky that my aha moment came when I was in dental school.
Oh,
So it
wow.
kind of came from the get go. but it wasn't necessarily Airway. But so I'm a third generation dentist, and I still work with my dad. He's still young enough and loves it too much to hang it up yet. So when I was in dental school, he was going through some TMJ curriculum through a group called OBI,
Mhm.
and they're all about skeletal stability and skeletal stabilization in relationship to everything. So they let me just tag along when I was in school, and at that time I had no idea, but my eyes were open to this stuff, and it's like you can't unsee it.
Mhm.
So I met a lot of amazing people, and this one orthodontist, Dr. Mary Burns, who is up in the New England area, and she's been my probably most amazing mentor with TMJ, and she was the first person to ever talk about Airway, probably you know 12, 15 years ago with stuff. And
Wow.
so like all the TMJ curriculum years ago, then eventually you realize, well, hey, all these TMJ patients are Airway patients. When you start learning more and taking the dive, and then it's like, okay, well, all these adults that you're treating have TMJ and Airway. Well, why do we know what's wrong? Why don't we fix it on the kids?
Mhm.
And then so I started getting much more into treating kids, which is predominantly what I do now. And so it's just like one thing led to another with all that stuff. And then, when it came into Airway and you just keep learning, then I found the Breathe Institute and started getting into ties and myo. And I got a myofunctional therapist that works in my office and on my team now. And so it's just, now my favorite thing are, you know, tie releases, and then do an early orthodontic intervention on kids. I do a
Mhm.
lot of early expansion on kids under the age of 10, and start intervening on just like, developing airway habits from a young age. And that's my favorite thing now and
Mhm.
stuff. Yeah. But yeah, then as you learn it, all this stuff, right? Like then I realized, well, I have all this stuff, so like Dr. Zagi did a tongue tie release and a nasal procedure for me to help me breathe out of my nose. And my dad's helped me with my bite and TMJ, all these things. So like when you experience it, it definitely is a great way to be able to communicate it with others too.
1,000%. I always say
Yeah.
to my patients that I wish I was tongue-tied so that I can have the procedure done, so that when
Yeah.
I talk to you about it, I can actually talk about it on a personal level too.
Yeah.
Um,
I didn't know mine was that bad until he did the procedure, and he's like, oh my, he's like, this was one of the deeper ones I've done in a while. I was like, yeah, thanks. He's like, you're gonna be sore. And I was sore.
oh, I'm
But
sure.
part of it was like, I really was like, I just want to experience it. I want to see what it's like. So I'm like, go ahead and do it. And
Yeah.
then, but then it ended up being a really good thing, because it was my missing piece for why I felt like I was always clenching, and why my jaw was always not painful, but just like sore at
Mhm.
times. And I was like, I've done all this other stuff. Like, why is it still? And then I realized, then afterwards, like that cleared it up almost instantly. So
Yeah,
that was a
absolutely.
good thing for me.
Now do you have a CO2 laser? You're doing the releases in office, or how do you do
Yeah. Yeah. So I mean, I have a laser, but then with my one-on-one training with Dr. Zagi with that Breathe Institute affiliate, um, he made it where I was intimidated, and then now it's much more, I'm much more comfortable with doing the scissors and
Yeah.
sutures and all that and stuff. And so on anybody who's older than at least, a couple years, always, try that. And most
Mhm.
most older kids and adults, it's always scissors and sutures, and then the young ones laser in that. But I think when you put sutures in at the end, what I've seen, the healing's always better.
Yeah.
It's
I prefer
always much easier for the
sutures.
families. And
Yeah. But then, and that's pretty much the bottom line. Like, we'll make sure it heals okay either way. But,
yeah.
as you know, when it comes to placing those sutures there, we don't have to be super aggressive with those exercises in those first few
Yeah.
days. And really, even in that first week, it's more so just light, gentle stretching. So,
Yeah.
I mean, that sounds way better to me than the alternative. But if we have to do that and have to get in there, then we will do that too, and we'll make sure that the patients are prepped. Now, when we are talking about, I know you are treating a lot of pediatrics and early intervention and expansion. Can you touch on? And I'm sure it depends on the patient's age and growth and whatnot. Are you doing mostly fixed expanders? Do you do removable guidance appliances? You want to talk a little bit about that?
Yeah. So I do all the above, and it really depends on the patient's age, their maturity and
Mhm.
behavior and cooperation, what it seems like they can handle at that point in time. Do they need other therapy as well? What are the parents' goals? And so it really, and this goes for any age, but, really just starting to sit down and listen to what their problems are first. And okay, like this is what's going on. What would your, like, if we could wave our magic wand, what would you like to see fixed? And,
Mhm.
kind of listen to them first. And then that will give me an idea of, okay, well, these are the problems. These are your goals. These could be your choices. And so within your choices, it's always, I want you to be able to take ownership of what's going on,
Mm.
even if it's with your kid, then you'll be more motivated and, more apt to do it.
Yeah.
But everything about it, all the pros and cons and things. And so for me, it always starts with that, making sure that they know what's going on versus me just saying, this is what you have to do,
Oh my God, it's so
and
important. And I love how you said that, asking the patients what their goals are.
yeah,
That is just so important because it can be so incredibly overwhelming to come have a visit with, you or me as a myofunctional therapist. And, even sometimes I get them before they see the airway dentist. I'm the one making that
yeah,
referral. And they're like, whoa, like I
yeah,
thought I was just coming in here because, my kids' lips are apart and I would rather them
yeah.
be together. And now you're telling me X, Y, and Z. And
Well, and
sometimes,
I think there are so many different ways to measure success, and
Mhm.
the success is dependent upon, what the patient perceives. And so,
Right.
if they come in and you see like, okay, well, I could do like 5 phases of treatment, that could be like $25,000, but they're like, I only want phase one, and that's what's going to make me happy.
Mhm.
And if you do that and they're comfortable, or, whatever the outcome is, then that's successful, right? Like it may not be in our eyes because we haven't done everything that we think that maybe, but,
Right.
in their eyes it is. So I think it always is a give and take and listening with that. So especially with the kids too. And these parents, I think, are pretty overwhelmed because there is so much info, and they have, somebody like maybe their pediatrician tells them one thing, somebody else tells them something, and and then they find something online and they come in and they're like, well, what really is going on, or like what's the truth in that? And so it's like, okay, when you start to unpack everything and break it down, it's like, okay, well, maybe you're 4 years old and you can't sit in the chair very well yet, and you're having these problems. So, I think for general dentists too, it's something where we get accustomed to, you see something, like you fix it,
Mhm.
but it's like, a pretty short timeline. But,
Right.
orthodontists or maybe other people are trained where, it's a long timeline,
Right.
and you see these young kids and you're like, okay, well, if they're starting out at 4, well, you have, maybe 10 years to work with them and
Mhm.
do things. And so it's, it's telling people it's okay if it's not all done like right now.
Right.
You're doing the right thing. We've identified it. You're going to be able to fix it, and we're going to be able to get it done when your kid is ready. So,
Exactly.
maybe if behavior's not there, you're doing therapy for 6 months or a year or
Mhm.
however long. And then, or maybe if they are ready, then maybe you start in something removable, or maybe it's something fixed.
Mhm.
And then you just kind of slowly keep working them until, you are, because it's always going to be a work in progress. I mean, you're
Right.
always going to be guiding, in my mind, to kind of that final place.
Yeah, absolutely. And at the end of the day, you'll get them where they need to be, but you're meeting the patient where they are. And
Yeah.
I love that, like sequence of care is so important to you because you don't want to overwhelm them to the point where they don't do anything, where they're just
Yeah.
like, I don't know, I'm just
Yeah.
not going to come back and see you. You told me way too much information. So
Yeah. But
listening to
I
them.
think exactly, listening. And then I think, um, for me, the secret weapon is always having a CBCT machine,
Yes.
and having a scan where you can see so much information on that, where, if you can get one on, say, even just a limited view, on like a 5-year-old or a 6-year-old or an adult, then it's so much easier to break it down and be like, okay, well, we see your arch is collapsed and way too small, your airway is small, you don't have tongue space, I know you have a bad tongue tie, but if we do a release, like maybe it makes the airway worse. So, let's develop the arch first. Let's,
Mhm.
get the teeth in a better position. Let's get you feeling better first. Then we can do the release. It's like, it's not an emergency tongue tie release, right? let's focus,
Right.
let's focus on these things and stuff to see how things, gradually get better and all that. Or maybe it's the opposite. They have tons of room, but they just have crowded teeth and they need a release or something. It's like, cool, okay, well, let's do the release, let's do your therapy, then we'll work you into all that
Yeah.
stuff. And, knowing it's a process. So it's just kind of seeing where it's at. Or like with my TMJ background, it's looking at where, from a skeletal standpoint, when you take a scan, you can see so much on the scan from where the condyles are, where the hyoid bone is, how the maxilla and mandible fit together to determine, are your airway measurements actually correct?
Mhm.
Is the skeleton just so far off that you can't even diagnose properly? So
Right.
maybe you have to, and that's what I'm big on. Like, we have to get the skeleton in the right position, then everything else falls in place, like your soft tissue, your myo, and all that. Cause, I'll see patients that like, I've been doing myo for like 2 years, or I've had like 3 tongue tie releases, and, I've had all this chiropractic work, and
Mhm.
no one's ever taken a scan. And then you get one and their airway's tiny, or their joints are, degenerative. And, so their problems skeletal, but they've had all soft tissue work. So it's looking at both. It's having providers that
Right.
can kind of meet in the middle with all that stuff. And
Now, do you do any expansion on adults, or are you mainly just with kids right now?
I do tons with kids, and I do some with adults as well, with all that and stuff. Adults is always just a little bit more tricky with that. I've done it long enough now where I know realistically how some of it works out. And I think it takes the special adult to really follow through with everything, because they can just get so burnt out, because it's
Yeah.
not 6 months like kids. It could be, every bit of 2 years at
Years.
times.
Yep.
And
Yep.
then they may need ortho, or they may need something else. And so, I find a lot of adults are motivated at first, and it's really hard to keep them going for,
Mhm.
a couple years and things, because they're just doing so much. And
Now,
so,
when
I
it
mean,
comes to your cone beams, are you're using those as education for the patient as well, correct?
yeah, I always sit down like that day and just point out highlights, because I mean, used the cone beams long enough, and I mean, I feel very confident reading through everything on those, that it is very simple to sit down and point things out to patients and parents, especially moms. Like, moms are always like, "Oh
Yeah.
yeah, I see that," because you can show them what's going on in the mouth first,
Mhm.
and then you can use the CBCT to verify that and say, "Okay, see
Right.
what we showed you here. We see it on here too." And like, "Oh yeah, that okay, I see that. That makes sense." So it's a good validation tool as well, and I think it builds in that value to, your exam or consult, or,
Mhm.
to them to see those numbers and measurements. Like, numbers are just all relative, I think, to me.
Right.
And it's there because there are so many variables, but it's a good tool. We all like to measure something.
Mhm.
As a kid, I'm like, I love baseball cards. I love stats. I like numbers. We
Yep.
like numbers. And so that helps.
Now, when it comes to, you talked about how, tongue space, we want to make sure there's space. So maybe we hold off on the release till we expand. Is there ever a time where maybe you would do the release in like two steps, where you'd release once to reap the benefits of that, go through expansion, and then,
Oh
recommend
yeah.
a revision?
Yeah. Or there are, or maybe cases where it's, hey, we know you're going to benefit from both, and and you're already on board to doing the expansion. So okay, well, let's do the release. You've already had your great mile. Let's do the release, and then you're going straight into expansion. So you're going to
Right.
gain the volume with all that, and then when you're done, go back in to do a little bit of myo
Mhm.
to relearn, how to utilize the new position in space and where the tongue needs to go, and that can work out great as well. Or, sometimes expansion is, maybe you can only do a little bit on a 5-year-old,
Mhm.
and then you've done enough and they get older, and then maybe you do another round when they're like 10 or 11.
Right.
So then you have like an in between where you can do whatever therapy or release or whatever it may be in that time frame too. So that's why I said it's always a long-term continuum, like thinking about all that, to where it may not be done like perfect now, but you just kind of keep checking in and keep, evaluating growth and development.
Now, do you get a lot of like I was just talking with Dr. Gelb recently, and he was saying how a lot of the women that come into his practice complaining of TMD, a lot of them are like 16-year-olds
Yeah.
around there. And then
Yeah.
obviously later in life when they're going through more
Yep.
hormonal changes and whatnot. Do you
Yep.
get a lot of like younger female
Yeah, that's
TMD?
like, so for exactly. And I mean, and he's right with the hormonal aspect of it, that especially for TMD, like teenage women and then like middle-aged women are the ones that you see the most, at least with pain.
Hmm.
And their body may tolerate it the rest of the time, but pain, especially at those ages.
And do you see a lot of like retroclination of those anterior teeth where they're really, kind of shoved back there. Because I feel like that's what I see on a lot of my TMD patients.
Yeah, so I call it dental jail.
Yeah,
Like
I love that.
yeah, like their mandibles trapped.
Yep.
They have nowhere to go. It's why you don't see like class 3 patients with TMD that much.
Right.
Um, but and it's all from the maxilla is always the culprit,
Mm-hmm.
and so it drives the mandible back, and then it leads to the whole sequela of issues that are going on with that and stuff. Yeah, but I mean that's probably like the most common thing you see with that is the mandibles trapped, the condyles are pushed down and back, and then they may or may not have a list of all these symptoms.
Right.
So it's just kind of, yeah, but yeah, that's probably the most common thing you'll see
Now,
with
if
that.
you have somebody that comes in that's in, like acute TMD pain right now, do you treat them with some kind of like orthopedic appliance first and then head towards more of like expansion? Like what would kind of be like your
Yes.
sequence of events for
Yeah.
that?
No, exactly. And I bet Dr. Gill hinted on that as well, where, you got to put the fire out first. Like if their
Mhm.
joints are, especially if the joints, like not only are they in pain, but is the bone, is it actively breaking down? And that's the power of, the CT scan is you can see, is the bone degenerating? And then if it is, you got to fix that first
Right.
and get them comfortable. And that's the primary thing. You got to save the condyle, especially on young females, because if they come in with an open bite and they're 15, you 100% have to rule out, are the condyles melting away? Like, is something going on with that?
Mhm.
And so you always treat that first. And then, because what will happen a lot of times, if the condyles are not in the right position, and then you do orthotic therapy and you get it lined back up and they're comfortable, all of a sudden their occlusion may look way different.
Right.
So your diagnosis a lot of times is way different, like 3-6 months into orthotic therapy than it is beforehand.
Hmm.
So it's always, let's do this first, and then it's going to reveal to me what the next steps are.
Right.
It'll reveal where the teeth should go to keep your jaw in that healthy position, or will reveal maybe how bad your airway actually is. The
Hmm.
people that get worse with orthotic therapy, it's not that it's making them bad, or it's not making them worse. It's just revealing how bad they actually are, or the
Right.
airway and stuff. And
Right.
so you can use it as a tool to not only get somebody comfortable, and so it can be therapeutic, but it can be diagnostic as well. It can give you a blueprint of, okay, well, what's next? You like,
Mhm.
how bad is it and stuff.
Right.
And so
And I like, another thing, and I keep bringing up Dr. Gelb just because I just listened to him lecture
yeah,
literally last night, but he was showing this like these two pyramids and like, out of dental school, you're learned to look at the teeth first. And like
yep,
now that you're invested in years of doing all this airway stuff, like the teeth are literally the last thing you look at.
yeah.
And it's I'm sure, I mean, for you, you had that experience like coming out of dental school, but like if you, I don't know, if you were in a room with like other graduates from your year in dental school and you were, talking to them about all this airway stuff, like what would you say to them? Do you think like a lot of them would look at you like
Well,
seriously?
I think that's a very loaded like topic, like to especially for a graduate and stuff, that I when people talk about tongue ties or airway, or all this stuff that may seem advanced, it's and when people say, well, there's just a lack of education, like we don't get taught about it and stuff, that and I think it's really hard. How do you teach it in dental school? Like,
Hmm.
or how do you teach it in some of these schools? Because it may be beyond a level of where we need to go. So like, as a dentist, if you're treatment planning cases, I mean, you have to focus on where the teeth go in harmony with the lips and the tongue and the airway and the joints, and our muscles, and how everything functions together. And when parents come in and say, I want my kids to have orthodontics, but I want to do it because it's a functional reason and not because the orthodontist is going to tell me, well, I can make them have a pretty smile. I hear that all the time. And so, you know, to me, it's like, health is beauty.
Hmm.
And when somebody's comfortable, they're going to have a good outcome.
Right.
And so, and it's going to look good. And so, that's the way I kind of explain it to the parents, is that we're not concerned about the aesthetics, but all those other things we just mentioned. But then when all those things work together, it's going to look good. So
Exactly.
you're gonna hit both of those. But and that's what's hard for, I think, when you're in school. Like when I was in school and tagged along with my dad, like it was so far over my head. I'm like, this is so cool, but like I don't know. And but then it's always like, well, where do you start?
Right.
And I think that's the hard part. And that's what in school, like they have to teach you the basics. Like you learn just enough to like understand the basics. And then it's like, okay, well, now dive into it. And I, I've thought about this before and talked to other people. And I think it's a really hard concept on where to start. But I think just for me and my journey, the thing that helped me the most was starting with the skeleton and
Mhm.
with some TMJ stuff and thinking about that first and getting that in alignment. Then you can focus on the soft tissue and the airway and all these things. But they really do go hand in hand. So
Right.
you got to look at if you're going to look at it, you have to learn the whole picture. And
Mhm.
so, but it's always going to be a continuum. Like you can't, as like I graduated, I'm going to learn all of this like this year. Not
Right.
going to
Oh my
happen.
gosh,
It's
there's
like
so much to learn forever.
find your, I've been blessed with some good mentors and stuff. And so it's like, find your mentors and hang out with them and do study clubs with them and talk
Yes.
to them. And, like every time I talk to, that Dr. Burns I mentioned, I'm like, I always learn something every time. Or even Dr. Zagi, like you always pick something up. Like,
Mhm.
so it's always going to be a process.
Now, how did you get introduced to myofunctional therapy?
Um, so one of my hygienists that she was just working part-time with us at that point, and she came and she's like, hey, I think I want to get into, I get this myofunctional therapy or something, or, thinking about, what it is. And it was just like, and since she was only part-time at that time, I didn't know everything that was going on. And I was in the process of going down and doing some some education, with like through with DNA appliances or some expansion or some
Mhm.
things where I started getting more into hearing about myo. And it was like very serendipitous. It was like we
Yeah.
both came at the same time, and then so started doing a lot of it together. And so I just started learning and hearing about it through some other organizations and things. And then she just kind of came to me. And then when she wanted to get into it, I was like, hey, do you just want to come work full time for us and do this?
Oh, that's
And so
amazing.
so it's been a really good partnership having someone that you can work with closely and bounce cases off of and all that stuff. So it's been nice.
Absolutely.
Yeah.
And then I wanna definitely, circle back to how we started the conversation about how pleased I was to receive your report when it came time for that patient that we worked on together and you did the release. So you called it, or you actually meet with them before you called it a readiness check.
Yeah.
So can you talk a little bit about that and like what you do in that appointment or talk to the patient about or assess for? Because I think it's so important. There's some release providers out there that I think do a really great job releasing, but maybe still don't 100% understand the full functional component. And I know that kind of makes
Yeah.
kind of sense, kind of not really make sense, but I have experience with some providers that way. Like I was pleased with the release, but I think that like if I sat down and went over the report with them, they'd be like, "Why are you looking at all of this?"
Yeah.
So I loved hearing that.
Well,
That
I so that's a concept I took from Dr. Zagi when I did my training with him. So that's not my original idea with that, but the whole point behind that readiness check is that, especially if you're working with other myofunctional therapists that you may not be familiar with, or even if you are, it's just that final validation to make sure the patient is ready for their surgery. And mainly for the fact that that if they can do their suction hold, or hold a position with no compensations, so no floor of mouth lift, or no neck strain or jaw tension
Mhm.
when they're doing it, I find that the release is more efficient, and there's more of the tension that's brought to the surface. So when you're doing the release, it's more effective. And then I find it's also, the muscle is more ready. Like it's like you've prepared it. So even if you're doing scissors, when the miles have been done really well, there can be almost no bleeding and like
Wow.
very minimal post-op discomfort. because they've done such good therapy getting ready for it. Just like if you do such good physical therapy getting ready for your knee surgery,
Right.
and you're going to be set, but then it's also going to make the aftercare more successful, because if they can do their therapy without these compensations, especially floor of mouth, then you're going to get healing with less reattachment and
Mhm.
less tension, especially when everybody's like, well, I don't want it to reattach. You're like, well, I could show you my tongue and I had a really deep release and I still have a frenum. Like it's gonna be there. We're just trying to
Right.
reposition it with less tension, better function, and more mobility. So it's trying to make sure, okay, are you ready, so you have the best outcome you can have.
Mhm.
We don't want it to go in, because like I'll have some families that come in and that were referred in, and they're like, yeah, we've been doing all the myofunctional therapy, all that stuff, and I'm like, show me your suction hold, and they had no idea what it was. Like couldn't even move their tongue, but they had maybe had like myofascial therapy,
Mhm.
and get it confused. And so it's just making sure that they're ready and it's going to be
Yeah,
successful. Yeah.
absolutely.
Yeah.
Um, it's funny. I make sure now to tell all of my release patients that you are still going to have a frenum, because I will have this
Yeah.
little boy come in. He's like, Miss Brittany, I don't think that the surgery worked. Look, I can still
Yeah.
see my string.
I know. That's so true. Like, especially for parents and babies, because they're always like, but there's still something there. It's like,
Yeah.
it's okay. Like, are they functioning well? Yes. Like everything's fine, but I still see it. And I'm like, it's fine.
Yeah.
We're
Yeah.
good. Yeah.
That's
But like those readiness checks can be like very quick. It's, it could be 10 minutes, like, especially if therapy's done well. And then,
right.
then it's a way to communicate with the therapist if needed. Like, hey, it's not as much like, well, why didn't you do this? What's going on? It's like, well, tell me what's going on. Like maybe you were doing great therapy, but they just didn't follow the directions.
Right.
And so then it can be a good way of trying to get an idea of, how the case is, and all that. And if the patient's really, motivated or ready, and, or whatnot. So
Absolutely.
you may learn some things from it as well
Now,
with
do
that.
you recommend body work to be done before and after releases as well? Do you guys work with certain people
I,
in
I,
your
I, I
area?
do. I do. And it depends on what age,
Mhm.
and then, maybe what their issues are and things. And, I think that's something to where, you may be able to help chime in on this as well, maybe with what your area. But, I find in my area in Kansas City, it's, over the last couple of years, it's something to where that's like as more people are, potentially getting into this field, that's like a raging topic, right? Of, well, who should see him first? It's
Right.
like they need physical therapy, they need myofunctional therapy, they need chiropractic work, they need speech therapy, they need occupational therapy. And it's like a lot of people are like, well, I need to see him first. And then these parents like, I can't see like 6 providers,
Right.
so like, who should I see? Who's best able to handle it? And, I think that's an area that, at least probably across the country, could be improved upon, of like trying to get a little better. And I know there's so much overlap though, so it's not going to be always
Right.
precise, but, working about trying to, get a sense of who may be the best person for, each kid or adult to, kind of guide
Exactly.
them.
Because
But I
like
think
you
that
said,
a lot of it's dependent on age to me too.
yeah, and people can't do all the things, even though
Yeah.
we might recommend it and that might be best. Like you have to meet people where they are. And if they
Yeah.
can't financially, whatever the case may be, they're still going to benefit, from the release.
Exactly.
They can do the
Yeah.
release and do some myo. And
Yeah.
that's why, I do recommend body work a lot. But not all my patients will follow through with it. Again, more
Yeah.
so I stress it definitely more so, like you said, age dependent.
Yeah.
Um, like I get a lot of um phone calls for babies and I'm like, go see a craniosacral therapist.
Yeah. Yep.
Like
Yeah.
I will do the active wound management with you. So you know what stretches you need to do and whatnot. But, for babies, I think that it's really important that they're getting that body work done.
Yeah. And I think the body work for the babies is definitely like very important. But, I think it's almost more important at times to focus on what are they really concerned with, like feeding,
Right.
and like lactation work, or, a therapist that can, I think body work's great, but if you're just focused on the body, I think they're missing the picture of the function of the tongue and everything,
Oh
where,
yeah. Well,
you
hopefully
trying to
they're already
trying to get
working.
trying to get a provider who can get, in the
Yeah.
mouth with all that. But because I see cases where, and this is where it's always like, it's not always black and white, but families that come in and they have a significant tie, but like you said, financially couldn't do anything
Mhm.
else and won't go anywhere. And so you're like, okay, well, we'll do it, and realistically these could be the outcomes, but then they do amazing.
Right.
They do amazing, and then no issues, and then have families that come in that did like 3 months of all this amazing therapy
Mhm.
and struggle afterwards,
Right.
like have a really hard time. So I don't know. I think there's a fine line between maybe just enough therapy and too much, especially on like like at a certain age of, how much is the tension really affecting something? And if they, for 3 months, even though therapy's there, they're still developing habits, like how easy is it to get them back?
Right.
So I don't know, man, but I think that's an avenue where there could be more, I don't know, research or collaboration on trying to figure out how some of that could best work. Because
Yes.
I
Yes.
see
Yeah.
so many different
And
scenarios with that.
oh yeah. And I totally agree with you as far as, infants go. I mean, and a lot of the infants that we do see or get phone calls about or that you're doing releases on, I mean, almost always they're having feeding issues, right? I mean, it's
Yeah,
very abnormal to be treating a infant for tongue tie and then to be like, oh no, feeding's going great.
yeah, yeah, exactly. And I think it's mainly the like under 1.5 that some of this conversation is centered around. And then as you get older than that, the therapy I think is like I'll tell the parents, like, I won't do it without this type of therapy. Once they hit a certain
Right.
age, just because it's, especially for the parents, I'm like, if you're doing it on a 2-year-old, I mean, they're you both are going to hate it if you don't have therapy beforehand, getting the kid ready for stretches or whatever it may be.
Mhm.
So yeah, there's definitely a line of when you get to a certain point, it's like, okay, well, we're not just doing it.
Exactly.
Yeah.
Now, with the like 2, 3 year olds, or even like 1.5, what have you, will you do releases? Will you? Okay, let me backtrack on that question. Are there ever times where you recommend waiting if for the patient to get a little bit older, maybe a little bit more mature? Like if you think that, maybe the post-op care isn't going to be the greatest. Is there ever a time where you're like, oh, I think we should maybe wait a little bit, or are you always doing the release?
No, I think there's times when um you can say like waiting, especially like if their function and symptoms and things are not, too significant, and the parents are, like, well, I just want to see what's going on. And you can see something in, but the hard part is, as we know, you can't say, well, because it looks like this now, you're going to have this problem later.
Right.
So that's always, because the parents always want to know that, well, like, if I don't do it now, will they have a speech problem? Will they have a feeding problem? You're like, well, I don't know, like, maybe, but
Right.
so, I look at it more from some growth and development at times, like, will it impact the growth of their jaw or their airway or their habits and things? And, and if it seems like it will, and they've tried a little bit of therapy and it's just not kind of getting over that, then we'll have a conversation of maybe do it sooner than later.
Hmm.
But if their symptoms are more mild and they're doing okay and therapy's improving a little bit, then I don't see a problem in having them wait
Right.
until they're to where it can be less traumatic for the kid. That
Yeah.
2 to 4 range is like,
It's tough.
is so tough for everybody involved
Yeah,
on,
1,000.
how successful it may even be, or the aftercare and all that
Mhm.
stuff. And so if we're going to do it between that age, I want to make sure that it's done in like the best way it can with
Optimally,
everybody involved
for
with
sure.
that. Yeah.
Now, when it comes time to talking about sleep, or maybe recommending a sleep test for a patient, are you guys working with sleep physicians? Do you give out sleep studies in your office and then have them read by physicians, or how does that
All the above.
work? Okay.
So like in my office, I call them sleep screenings.
Hmm.
So I don't get it confused with like trying to say, hey, I'm the physician and practice in medicine and all
Right.
that. So, I just say, let's screen what's going on first, because you can do it at home and it's inexpensive, and,
Hmm.
it gives us just a quick snapshot of, one night of what's going on. But then it can help me, because if it comes back, if it's, doesn't even register as sleep apnea, but maybe like upper airway resistance or just sleep disordered breathing, or maybe it comes back as severe sleep apnea,
Hmm.
then that kind of dictates to me, like, do I need to get a physician involved, or what appliance that I have like
Hmm.
would benefit them the most? Like, should they be on a CPAP at the same time they're doing their expansion, or what's going on, or the people that have all these symptoms, but it comes back like almost no sleep apnea. And I'm like, you need to see a physician because there's something else
Right.
systemically going on. So I get a lot of information from it, and then I'll, always give the disclaimer, like I can talk about it, but I can't diagnose off of it. So
Mhm.
we can have a conversation and it's going to guide me. But if we need the diagnosis, we'll get the team of physicians involved and people to try to help.
Now, what sleep screening questionnaires are you doing in your office?
Um, so I I have the watch pad as far as the sleep study I have at home, and then they have ones that are nice that you can give people that are disposable. So it's like a
Mhm.
one-time use. So it's been great with COVID or people that drive in from a ways. They can take that. And then I use the standard ones that I'm sure everybody does with like the Epworth and Stop Bang and
Mhm.
a few others, but then I've kind of for other ages compiled my own between a handful of
Mhm.
ones that are like groups that have been out there and that just
Yeah.
questions or red flags and things and stuff.
Yeah,
So
because
yeah,
sometimes it's kind of crazy how often I find somebody like scoring somewhat low on like the Epworth screener, but
yeah,
like that there's something going on. You know what I
yeah,
mean? So I think, having those questions more symptom based are definitely really important to be asking and having them part of your medical history and your standard questions that,
yeah. That's why I think Airway becomes very tricky nowadays because it's so dynamic. Where like you mentioned, these people, they complain about how bad they feel and they don't sleep and this and that, but you do screenings and their forms and things check out pretty good,
Mm-hmm.
or their sleep test comes back like almost perfect, but yet
Mm-hmm.
they talk about how bad they're feeling. And you look in the mouth and the teeth are all worn out, you can tell like something's going on.
Right.
And those are always like the most challenging ones because it's not the most obvious, but then everybody, that's the patient who's always very frustrated, like, well, if you just told me like I have severe sleep apnea, then I know what to do.
Right.
And
Right.
you just have to like, I think just with my own experience for myself, like my airway measurement behind my tongue was like 4 times the size of what it should be.
Okay.
But I did a sleep test and had mild sleep apnea, so I couldn't breathe out of my nose at all.
Right.
And so that's really improved after my procedure. But, it, that those are always the most difficult cases
Oh, for
on
sure.
adults like
And
that.
yeah.
I love kids because kids are very straightforward.
Mm-hmm.
They're moving forward and you're helping their growth. But those adults that are kind of in that gray area, you just have to, in my experience, try a handful of things,
Right. And keep
and see what
probing and finding,
exactly like,
what's going
each,
on.
and I think they have to really take charge of their own health. Like, okay, well, try this certain type of diet or try this type of, or try lip taping or try this nasal rinse or try,
Right.
doing this before bed or like developing your own routines and, things like I wear an Aura ring, when I sleep at night. And I know that if I eat dinner too late or even just having like one drink at night, like my
Yep.
deep sleep goes way down. So I think it's like
Oh,
for
yeah.
each person trying to figure out where the triggers are, because it's not the
Mhm.
same for everybody. And that's why the treatment plans are hard. It's like, well, if I put you in this one appliance, you're going to be better. I
Right.
don't think that's fair to say to everybody. It's kind of, well, you may like, but we got to try these other things and rule it out. And that's where it becomes more tricky with adults.
Yeah, definitely.
Yeah.
Definitely. I just got one of those, the oxygen rings. Well, I think is the company,
Yeah.
that you wear at night. I wanted to try something, um, to just kind of monitor really my oxygen levels at night.
Yeah.
I am going to have a sleep study done at some point. It doesn't happen often, but there are times I wake up and my heart is racing.
Yeah.
Um, and of course, when I wore the ring last night, it didn't happen and my oxygen levels
Yeah.
were great and I slept like an angel. But I'm gonna definitely wear it tonight because, like I told you before, we're going to a wedding tonight, so there
Yeah.
will be some drinking involved.
Yeah.
So I'm really curious to see the
Well,
difference in
that's
the
the thing.
result.
I think it's just like, yeah, you just have to see what's working and what's not, and try to validate it through all, since there are like so many different easy ways, right? Nowadays with whether it's,
Technology, yeah.
what you're wearing or like the Whoop bracelet or like an app on
Hmm.
your phone, we
Hmm.
can all do quick screenings for adults and even
Right.
sometimes kids, or, like my favorite thing is just telling a parent, just get like a quick 1-minute video of your kid,
Yes.
and
Yes,
it's like,
yes,
it
yes.
tells you so much information with that. And so, yeah, but it's cool. Like, I think, at least for me personally, it's so fun just to look at, like, the diagnosis is almost the most fun, and trying to, like, go through, like, okay, all this data, what's really,
Mm-hmm.
there, and, and what's going on with that. But
Yep.
yeah,
1,000%. I am
yeah,
actually I just saw a new patient before we hopped on, and two things that we talked about, the mom said, she was like, well, what is going to happen if we don't take care of the tongue tie? And same idea. I can't predict, I can't tell you what's going to happen,
yeah,
with your daughter, but I can tell you what maybe what some possibilities or outcomes might be, what we
yeah,
tend to see, or, what can happen. And then the other thing I said to her as well, um, because she knows she's sleeping with her mouth open. And then when we talked about like snoring or audible breathing, she was like, oh my God. She's like, I don't even, because, sometimes parents, they don't even think to pay attention to these things. So then you start
yeah,
asking them all these questions and they're like, ooh. And I'm like, it's okay. You're going to go home. You know what you
yeah,
need to pay attention to. I literally want you to take a video 3 nights this week, and I want you to send
yeah,
it to me. And then all of a sudden they come back with all this information to give you.
yeah,
You know what? She does chew with her mouth open. Food spills out. She
yeah,
does drink a lot of liquids with her foods. And you are able to get all this information. And I see right behind you, Sleep Wrecked Kids sitting up there. It's one of
oh
the
yeah,
best books.
yeah,
For parents, I think that it's so great just to have this education and different signs and symptoms to look out for that they just don't know, because it's not something that is always, talked about
yeah,
at your pediatrician's
yeah.
office.
There,
And
there are so many red flags that are easy to spot when they, I mean, I just have a check. I just have a little sheet of books and websites and things for parents to go to. So, because I mean, otherwise it just takes too much time to try to educate everybody,
yes.
in the hour or 30 minutes that you have with them. So it's like, go take these resources and take them home, just like you said, watch that video or read this book, or do something, and, educate yourself. And then if you think there's a problem, come back and we'll have another
Yeah.
conversation and stuff. And
1,000%.
because it goes back to like the beginning where we talked about, you have to take ownership a little bit too.
Mhm.
And, and that's why I think it's tricky with kids and adults, is that, you can do the best therapy possible, but
Mhm.
if they're not taking charge of what their own lifestyle is like too, it's tough.
Thousand percent.
It's like telling a parent, well, your kid has, crazy and large tonsils, and yes, I can do your expansion, but if they're going to be mouth breathing because their tonsils and adenoids are big, so they're not going to get as much expansion, or maybe their orthodontic work is going to take twice as long.
Right.
So if you do this is going to help. It's the same analogy I use with parents talking about fluoride. Like, if they don't want fluoride, or if they do, since I've got a pretty holistic practice, that, like, I don't care if you use fluoride or not. Like, I see
Mhm.
both sides. I'm not going to beat you up.
Right.
I see parents that don't want their kids to have fluoride, and they have tremendous amounts of decay.
Mhm.
And I see others that, are the opposite, and they
Mhm.
do totally fine. So I say, to me, it's like, it's a crutch for our modern lifestyle. If
Right.
you want to eat crap, then you may need fluoride to protect your teeth. But if
Yep.
you live a healthy lifestyle, you may not need it. So it's
Exactly.
okay. But I think it goes in with a lot of the airway and the growth stuff, that, it's not this one tool, like this one tongue tie release or this one expander is going to, solve it. And I think that's the hardest part for us, is that, we can't fully handle all those other factors and stuff. But, if they're there, you're going to have so much more success
Mhm.
with behavior and, compliance or outcomes, whatever it is. So, those parents that, when the kids are, following those guidelines and stuff, like, they're so much fun to work with.
Oh, 1,000%.
Yeah.
And I
Yeah.
think, to come full circle to what you talked about in the beginning, is knowing what the patient's goals are and listening to them. Because if somebody feels listened to, they're going to be more apt to follow your recommendations. If they
Yeah.
feel, you know what I mean? So I kind of like how we came full circle back there, but this has been
Yeah.
absolutely wonderful. I so appreciate you taking the time out of your busy schedule to chat with us. If people want to get a hold of you, see what you're up to, where can they, your website, what social media platforms, how can they find you?
So my website's holisticdentalkc.com. And, the same thing for Instagram, holisticdentalkc.com. KC for Kansas City. That's where I'm at. There's like the two main things. That
Perfect.
Instagram page is where I put most like info or stuff like that, but
Very
I don't do a
cool.
lot of too much other social media.
Awesome. Well, thank you
Yeah.
again so much. Anything else you want to say, chat about before we wrap
No,
up?
this was so cool. Thanks for having me. And it's always a pleasure to talk with other like-minded people and, I don't know, bounce ideas off and kind of spread a good message.
Absolutely.
Yeah.
Absolutely.